Now, our next session is on radiation, and our speaker was Dr. Mack Roach. Dr. Mack Roach is the head of the Radiation Oncology and Urology Department for the University of California, San Francisco. He's written over 200 papers when it comes to radiation, and this man has made waves in the prostate cancer community. He is somebody who has advocated for the patients, who speaks his mind, and really tells us just the ins and outs, the truths of what to face and what you're going to face when it comes to radiation, but kind of the nuances. And also, he had an incredible Q&A session with Dr. Mark Moyad, who always does a great job moderating our conferences. And so without further ado, here's Dr. Mack Roach.
They gave me a choice of whether I could have the mic here with the thing, or whether I could hold the phone like this. And I decided that if I was a singer like James Brown or something, and I was dancing on the stage, I like the mic up here so we can all have our fantasies. But, Mark, as you know, likes to confabulate. I don't even know if that's really a word, but he does it anyway. And we know it's all about education, Mark, at Michigan, okay? I'm gonna leave it there for now. I'm honored to be invited to this meeting. These guys and the lady, she hasn't aged, but these old guys I've been knowing a long time, and we've all gotten gray together, but we've been battling prostate cancer for a long time, So anyway, how do I get this thing to work? Let's see. So I'm going to talk about, I was asked to talk about side effects from radiation, and it reminds me of an old song from the 60s from a group called the Persuasions. Used to sing, there's a thin line between love and hate. So the problem with radiotherapy is that you want to, when you do radiation for a patient, you want to eradicate every single cancer cell. And in order to do that, you have to put a lot of radiation in that location. And you have to try to also miss some of the normal structures. And so there are complications which are mostly related to the local application of radiation. But I was just speaking to a physician who approached me a little while ago who had undergone a radical prostatectomy, and he was on hormone therapy, and he was afraid to get radiation because he was concerned about the side effects of radiation. And I just made the point, first of all, that radiation is the single most active agent in the treatment of cancer, meaning it has a broad spectrum of activity against lung cancer, head and neck cancer, breast cancer, all kinds of cancers. So when drugs stop working, including hormone therapy, radiation still works. And it's very effective treatment. And cancers are more sensitive to radiation than normal tissues. And a classic example is if you have cancer of your vocal cords, you can have a choice of having your larynx removed, and then you get esophageal speech, or you have some other type of procedure, or you get radiation and you can have a cure rate of 90% and you keep your vocal cords and you still are able to speak. So the bottom line is, if done properly, most people will recover from the major side effects of radiation. And in a man who has a radical prostatectomy and a recurrence, the only curative treatment is radiation. I will mention some biomarkers. I have no conflicts. I don't invest in any of these companies that have anything to do with prostate. In fact, I don't invest in anything. Anyway, I think Dr. Klotz kind of talked a little bit about this kind of data. This is 10-year outcomes from monitoring, surgery, and radiation. And I think, so these two lines are surgery and radiation, and this is freedom from disease progression. So although there are a lot of people that don't have progression that we can discern by 10 years, but clearly the treatments do reduce the risk of progression. One of the problems with most people's understanding of prostate cancer is our impatience and our lack of understanding about the timeline for radiation. So, some people are out 5 years, some people are out 10 years. We know that 25% of the men who recur after radical prostatectomy recur after 5 years. And if you look at any of those statistics, those numbers are still going down. So even if you're out 10 years, whether it's been surgery or radiation, you can have a recurrence. The probability of recurring goes down over time, but it doesn't go to zero. And frequently, as someone who's been doing this for a long time, I meet these young radiation oncologists, and they will do something, and they've been doing it for 2 or 3 years or 5 years, and they think they got it all figured out. And I'm like, dude, I got somebody that I treated 20 years ago, and 15 years ago, and 10 years ago, and I still see stuff. You just haven't been around long enough. And that happens, and I understand. They finish their residency, they get a job, they come out, they start treating people, and they think that they know what's going on, and some do, but many don't. So I talked about that curve that shows superposition of surgery and radiation with freedom from disease progression, but of course, continence and sexual function are better with radiation than surgery. That's known, that's a fact. This is a randomized trial with 500 patients on each group. But even in patients with metastatic disease, so this is a curve from a study in which they took people that had presented with metastatic prostate cancer, and their primary had not been treated, and they were randomized to either have their prostate treated or not. And you can see that having radiation even prolonged survival in some of those patients. So before this, many times when patients presented with metastatic disease, people would say, man, you have metastatic disease, just take hormone therapy, take chemotherapy. But the primary it frequently needs to be treated, and there are data that show that metastases metastasize. So they have clonal. So you have a bone met here and a bone met here and a lymph node met here. If those things are left untreated, those things can go somewhere else. So our aggressiveness in terms of treating metastatic disease has increased in part because of studies like the so-called Oriole study. They took a bunch of patients at Johns Hopkins. Some of them, and there's a term we call oligometastatic disease. These are the ones that are typically picked up on PSMA PET when the primary is controlled, the surgery or radiation, but they have a metastasis. And they randomized them, and they had some of the patients, they treated all the metastases, and some they did not, and you can see differences in the rate of progression. So I tend to be aggressive with these patients. We have a whole bunch of types of radiation. And the ones that we use for prostate cancer, we don't use gamma knife for brain tumors, but stereotactic body radiotherapy can be done with a linear accelerator or a device like the CyberKnife device. This is a robotic system here. I'm going to spend a few minutes on this MR-guided machine, and I'm glad that I chose to talk about it. One of the reasons I'm glad I chose to talk about it is because when I came back from lunch, 2 people came up to me and asked me questions about this machine and whether or not I was enthusiastic about it. And you can use it. The question is it better, and how good is the evidence that it's better? And the short answer is the evidence is not good that it's better. So these are the topics that I had planned to talk about. I was a little bit off script to start out with. Common myths concerning radiotherapy. And then I'm going to talk about some things that I think that are new, meaning that we published these things within the last year, including how important is age? How should age impact your decisions, or at least your understanding of prostate cancer? I used to do a lot of brachytherapy. I've done more than 1,500 cases of brachytherapy. I don't do brachytherapy anymore, primarily because it's inconvenient for me. And I tend to use stereotactic body radiotherapy. And then what about delays in treatment? Now, there's several types of delay. The delay is like, I got a biopsy, and I can't get an appointment for a week, or for a month, or for 6 months. How important is that? And then there's also delays during treatment. So we've had this problem recently at UCSF. The machine broke down a couple of times, and people's treatments with radiation was canceled, and my patients are frantic. They're sending me emails. You know, the machine's broken, and is this going to hurt me in some way? And so there are different kinds of delays I'm going to talk about. And then I'm going to talk a little bit about biomarkers, just a little bit. I won't have time to talk about immunologic aspects of radiotherapy, flash radiation, which is one of the most exciting areas, and then particle radiation I do research in. This would be protons, carbon, stuff like that. We don't have carbon in the US, but it's an area that I'm very interested in and been doing work in. So let's talk about some of the myths concerning radiotherapy. Here's one of my favorite ones. I've heard this so many times. Radical prostatectomy is better because there are fewer salvage options after radiation recurrences. Another version of that is, well, if you have surgery, you can get radiation afterwards, but if you have radiation, you can't get surgery afterwards. I see some heads going up and down. I think some people heard that before. Okay, that's horseshit. Okay, so we'll talk about that. And then another myth is MR guided is better. Let me see if I can went the wrong back. MR guided better. Another minor issue is hormone therapy first is best. So the classic way when people are going to get radiated is they start people on hormone therapy and then they radiate the patient. And that's the standard. But there are some nuances to that I'm going to touch on. And then I'm going to talk about race and prostate cancer. So this is what when I say it's horseshit. So this is a systematic review and meta-analysis of local salvage treatments after radiation. So these people, this includes all the studies that they could find where people got radiation and then after the radiation they got another type of treatment. So if you can see it, maybe not from the back of the room, radical prostatectomy. 52 studies involving 2,686 patients. All of these people got radiation and then they had surgery after the radiation. And you also have, this is cryosurgery, HIFU, stereotactic body radiotherapy, HDR radiotherapy, low dose radiotherapy. So some of these people are re-irradiated. So what you have here is more than 10,000 patients who got radiation first and then had the backup either surgery or radiation. So why urologists continue to tell patients, oh, if you have surgery first, you can get radiation, but if you get radiation first, you can't have surgery. I guess they haven't been reading. This is 10,000 patients, and there's like a few hundred papers on this that disproves that statement. Now, we use a term stereotactic body radiotherapy, and this is a slide that shows these are brachytherapy. This is high dose rate brachytherapy. This is a dose distribution. This is axial and sagittal. And what I'm showing you here is that the dose distribution of radiation with stereotactic body radiotherapy is very similar to brachytherapy. And the way that we do it is we have the urologist place gold marker seeds in the prostate, the base, the midgland, and the apex, and then we do an MRI and a CT, and then we do MR-CT fusion, and we use the detailed anatomy from the MRI to design the CT, to design the treatment. And then we circle those things, and then I use a CyberKnife, or you can use a linear accelerator. These little green things represent hundreds of beams coming from all different directions, focused on the prostate, and these little curve out in the white and here, this is our effort to spare the urethra, to make sure that there's no hot spot in the urethra. So that's what we mean by stereotactic body radiotherapy. And it's been studied extensively. This is one of the early trials, 78 gray and 39 fractions versus 42.7 gray and 7 fractions, showing similar cancer control rates. So you can shorten. So the typical patient that I used to treat with 40 treatments, I now treat with 4 treatments. So I tell my patients it's kind of like if you're going to buy a car, you can pay cash or you can finance it over 7 years. You know, if you pay cash, it's less. So we give half as much radiation, but biologically it's effectively more radiation. Now here's this MR linac thing. So this is a randomized trial, and I have great respect for the investigators. Dr. Keyshawn is I think he's one of the top young people coming up. But this study is problematic. Okay, so here's the deal. So this is a randomized trial. It's called the Mirage randomized trial. Now, when I first read this, I wrote a letter to the journal. This is JAMA. And JAMA sat on my letter, and then they told me it was too late. And I was pissed, and I said, okay, fine, you know. So then a few months later, apparently somebody else had written a letter to JAMA saying, because the company subsequently went out of business. So somebody else had written a letter opining about, oh, society and science is in bad shape. You know, this company is doing wonderful stuff. And so because they knew that I had written this very critical commentary, they invited me to writing opposing opinion. Now, what they didn't, they wouldn't tell me who wrote it, and they wouldn't let me see what the other person wrote. To make a long story short, it's been published, their letter. Actually, the senior author on the opinion was from Harvard, the chair of the department at Harvard, who was actually used to be one of my residents. So it was interesting that we had opposing views, but she doesn't treat prostate cancer. So this is a randomized trial where people are doing stereotactic body radiotherapy using either an MR or they call it CT-based, CT-guided. Now, actually, it's not CT-guided. There are fiducial markers. These are gold seeds that they can use orthogonal images to line people up and deliver treatment within a couple of millimeters. They're not using the CT image itself. They're using the seeds, which are visible on CT. And the primary endpoint was improves acute physician-scored genital urinary toxicity, okay? So in other words, they had the doctors there, and they also had some patient information, but that's the primary endpoint. And what they did in this study is they treated the patients that got the MRI, they used 2 millimeter margin, but on the CT patients, they used a 4 millimeter margin. And the conclusion of the study was that MR was better, it had less side effects. And so it was a randomized trial, and it was stopped early because the monitoring committee said, oh, look at this, it stopped early, you reached the endpoint that you wanted. Well, first of all, the first study ever written comparing the size of the prostate on MR versus the size of the prostate on CT, I wrote in 1996. So I've been looking at MRIs and CTs of prostates for a long time. And one of the things that we've also done that's relevant is we put one other company out of business. We didn't put these people out of business, but there was another device called the so-called BAT device. The BAT device was an ultrasound device that people used to put on the tummies of patients to guide their treatment. So one year at our national meeting, there was a plenary session. So a plenary session is the big session where everybody's in there. And there were investigators from Memorial Sloan Kettering and MD Anderson swearing about how wonderful the BAT device was. And in a poster session that nobody hardly saw, we had data that showed that the BAT system was inaccurate, that there was a systematic error of 5 millimeters sup to inf, and that there was tremendous inter-observer variability in terms of actually positioning the thing, because it was a fuzzy image. And one of the questions that's going to come up about so-called MR guided is how is it actually guided and what actually takes place? So the question is, how much better is a 0.35 Tesla MR compared to an ultrasound, which is what the BAT system used? And that's an unanswered question. But here it is. Okay, so let's assume this is a thought exercise, right? Let's say you have 2 MRI machines, and you do a randomized trial where you randomize patients to 2 mm margins or 4 mm margins. This is the volume of tissue you would irradiate, 70, and this is the volume you would irradiate, 100. And would you be surprised if you had more side effects with the 4 mm margin over the 2 mm margin? These are identical machines. Would it be logical for you to conclude that this machine must be better than this machine because of the side effect profile? So the fundamental flaw in the study design of this randomized trial was choosing different margins to evaluate before you did toxicity. So now what you have is you have an MR machine and a CT machine, and you're going to say this CT-guided image thing is worse because of the toxicity difference. But then there's another issue, which is, you know, when you treat somebody with radiation for prostate cancer, the prostate is mobile. And so the rationale for the 2 mm margin on the MR machine was that, we can adjust for the prostate position we can adapt. Well, you need to adapt because the MR machine, it takes 1,133 seconds it takes much longer to deliver the radiation than the CT-guided one, and therefore you have more time for the prostate to move and for the patient to move. So yeah, you better adapt, but then the other problem is they only made adjustments if greater than 10% of the prostate moved outside a 3 mm gating boundary. Well, they don't tell you how often that happened, and they don't tell you about the types of adjustments they made, so we really don't have any idea about whether that's a real problem in the first place or not. Here's another problem. These are the patients, they had baseline characteristics of the patients on the CT group and the MR group. And if you look, there were more patients that had high-risk disease on the CT group, more patients who had baseline GI comorbidity. In other words, people that already had baseline problems with their gut. And so if you add it up, out of these 77 patients, how many potentially adverse factors they had compared to the people that got the MRI, I counted 93 versus 74. This was not adjusted for statistically. So there was selection bias. And then, and I'm almost done with this MR linacs stuff, this is a study looking at patient versus physician-reported side effects with receiving hypofractionated radiation. That means shortened radiation time, okay? You can see patients are red bars and physicians are blue bars. And in general, patients always report more side effects than the doctors do. He's doing fine, you know, I'm writing the progress. No, he's just doing swimmingly, you know, and the patient says, no, I'm not, doc, I got this problem and this other. So this is what the data shows, okay? However, in this particular study, in this randomized trial, if they looked at genital urinary toxicity, which is one of the primary endpoints, physician reported more than the patient did. So the physicians at the institution that had access to the technology who were not blind, they knew who got the MRI and who got the CT. They reported higher side effect rates with the CT. So the bottom line is, and the patients didn't. Regarding this Mirage trial, I said, yeah, perfect name. There's a song, you probably, Smokey Robinson, The Love I Had with You is Just a Mirage. Romantic places. All right, so, you know, the margins were arbitrary, the motion adjustment, the evidence of potential bias, opportunities for placebo effects, no clinical outcome, substantially more expensive. They haven't convinced me that it's any advantage. I mean, if it's the most convenient place for you to go and you think the doctor is good, go for it. But don't be convinced that you need to travel to a distant location so you can get this MR-guided treatment. Now, This is about the sequence of hormone therapy and radiation. So this is the only phase 3 randomized data, okay? So what we did is we took 1,200 patients, and we randomly assigned them, with their consent, of course, 300 patients in each group to either get hormone therapy before radiation or hormone therapy after radiation, and whether to have their lymph nodes radiated or not, okay? Now, it turns out that if you only radiate the prostate, this is PORT, it's better to give the hormone therapy after the radiation. We don't know why. This is what we found. There are no contradictory data. So if I have a patient and I'm only going to radiate the prostate, but I think the patient needs hormone therapy, short-term hormone therapy, typically 4 months, then I radiate the prostate and give them 4 months of hormone therapy. Most doctors, I would say 95%, will give the hormone therapy first and then radiate the prostate. These are the data. So if you look at, now these patients are not like probably any of you. These patients on average had a PSA of 22. Most of them were clinical T3s. They had relatively advanced disease. And this is the biochemical failure. And you can see, so if this is the standard that most people go by, neoadjuvant, that's hormone therapy first and then radiate the prostate. This is the recurrence rate up here. The people that have prostate radiation first and then hormone therapy, they're a little bit below that. So it's a little bit better to give the hormone therapy after radiation. And this is an interesting paper. So this came out of an observation. I wrote a paper on testosterone and prostate cancer many years ago. And one of the things I noticed was that for some reason, the patients that were over the age of 70 in terms of cancer-specific outcomes did better than the patients under 70. And if you remember, Dr. Klotz spoke earlier, he was saying that age was an adverse prognostic factor for having more advanced stage. And so I had heard that before, and I knew this data, so it intrigued me. So we did this study where we did a systematic review and meta-analysis. We pulled all the papers we could find where the paper provided information on age, and they were treated with either surgery or radiation. And this is what we found. So I have to get a little bit closer so I can read this. So the orange are radiated patients, and the blue are patients who underwent radical prostatectomy. And so this is this is age 70 plus or minus 5 years. So we found, let me see how many there were, something like 45 studies. 30 were surgery and 15 were radiation studies. So just over 50% of the studies were patients 70 plus or minus 5 years. The age was a favorable prognostic factor. In other words, the older patients did better. Okay, age was a good thing, okay? And then another about 25%, there was a trend for patients to do better that did not reach statistical significance. And then another about 25%, there was no effect. So but there were no studies in which being over the age of 70 was a bad thing, okay? But then when we looked at the surgical papers, it was sort of the opposite. There were about 30% where age had no effect. There was another 15% where there was a trend for age to be negative. And then about 50% of the studies suggested that men 70 plus or minus 5 years did worse than the younger men. Now, what you do with this, I'm not quite sure. But the bottom line is it tells you something about the biology of prostate cancer and age. And I think it's interesting observation. Now, I talked about the fact that I don't do brachytherapy anymore, and I moved to doing stereotactic body radiotherapy. So for those patients with locally advanced disease where I combine pelvic radiation, we did a matched comparison at UCSF. Stereotactic body radiotherapy and HDR brachytherapy combined with external beam in patients with these are patients with high-risk disease. And what this shows you is that in our hands, they look the same. So I feel very comfortable. So if a person wants brachytherapy, we have 3 people in my institution that have a lot of experience doing brachytherapy. I don't want to do brachytherapy anymore. We have 3 campuses, and the main campus that does brachytherapy is at Mission Bay, and my office is at Mount Zion. And if I wanted to do brachytherapy, I'd have to drive for half hour, find somewhere to park, go to the operating room, wait around, put on my lead or whatever, and I don't want to do that. And I can get to my office at Mount Zion in between 5 and 10 minutes, and I can do stereotactic body radiotherapy, and it's flexible and it's easy to do. And I tell my patients, I don't want to do it. If you want brachytherapy, I'll send you to one of my colleagues. Delays in treatment and during treatment. So this is one. So there are many reasons for delays. You can have vacations, business trips, psychological stuff. There can be disasters, floods, earthquake, wars. There can be delays because of mechanical failures. There can be delays because of COVID. And then the question is, how much do these delays affect your chances of having the prostate cancer progress? So patients always, some patients, there was an article many years ago published, Arnold Palmer, after he got diagnosed with prostate cancer, he had a radical prostatectomy in about a week. And then there was a letter in the an article in the Atlanta Constitution saying, Arnold Palmer, who successfully underwent a radical prostatectomy, will now undergo radiation. So I'm not sure what they meant by success in that situation, but he was getting radiation, but he rushed into it. I mean, if you're a VIP and you know people and, you can get it in a week, more power to you. But the question is, what about most people? How important is the delay? So one of the problems is that there are not trials. Generally, there are no trials that answer this question, except for maybe one. And I'll talk about the so-called Patriot trial. But in order to try to answer this question, what we did was we looked at all the studies we could find in which patients were randomly assigned to either take hormone therapy and then do radiation, or hormone therapy and then do surgery, or immediate surgery, or other study designs that would give us insight into how much a delay impacted the long-term results. And there are a limited number of studies. Then we looked at retrospective studies that there have been a lot of papers written on, is a delay important or not? Now, one of the problems with those studies is that some institutions have a policy that if you have aggressive disease, they'll treat you first. And then the people with less aggressive disease, they would treat you later. And as a result, in some of the studies, a delay was associated with a better outcome than immediate treatment. So there's opportunity for selection bias. So this is one of the examples of studies with hormone therapy and radiation. This is one where patients were randomized to either get 4 months of hormone therapy or 9 months of hormone therapy. And in the group that got the 9 months of hormone therapy, these are with radiation, they gave 28 weeks of hormone therapy versus 8 weeks of hormone therapy before they did the radiation. And it showed no difference in outcome. The patients that did the 28 weeks did not suffer any problems because their radiation was delayed longer. Now, probably even more relevant to you is that if the people that got 9 months of hormone therapy did no better than 4 months of hormone therapy, why do urologists and radiation oncologists keep giving patients 6 months of hormone therapy? So if you ask doctors and patients, I'm going to get short-term hormone therapy, the most common duration they offer people is 6 months. But this is a study of 4 months versus 9 months, and it showed that there was absolutely no advantage to 9 months in terms of disease-specific survival, biochemical failure, but there was more side effects in the people that got 9 months of hormone therapy. So I don't recommend 6 months of hormone therapy when 4 months of hormone therapy is adequate, and 3 months of hormone therapy is probably inadequate. So that's the sweet spot for short-term hormone therapy, 4 months, in my opinion, and that's what the data support. These are a series of studies where they did radical prostatectomy with hormones before. It did not affect the outcome, didn't improve it, and didn't make it worse. So that delay was not a big deal. And these are some studies where patients were randomized between hormone therapy and with or without radiation. And the bottom line, the ones on the top, with or without radiation. And the bottom line, and then the ones below have surgery. The bottom line is you still need to treat the primary. That's the take-home message from this busy slide that you probably can't read, is that you need to treat the primary. You don't just give hormone therapy alone in people with locally advanced prostate cancer. And this is a curve that, this is from the PROTECT study. This is a curve I showed earlier. And this just shows that eventually those people, this is the PIVOT study, eventually there was a discrepancy in the probability of death that favored the treatment. So from these data, and then this is data from post-op radiation, and I'm not going to go over in detail. And these are the post-hoc studies, so obviously you're not going to read these slides, but the point is that we reviewed all of this stuff, and basically I'll give you some conclusions about delays. But this is the only randomized trial that really looks systematically at the duration of treatment. So these people were randomized between once a week and every other day radiation to the prostate. And the first observation is that doing it once a week had less side effects. And it turned out that the cancer control rate, and this is just the preliminary analysis, was similar. So the bottom line is that prostate cancer grows slowly. So delays in treatment, as I'll show you what my summary slide is, you don't need to be panicking. It's better to do the right thing than the fast thing. Take your time, look through things, make your decisions. Don't feel like, oh, the cancer's growing too fast, it's going to spread. No, take your time, learn what you need to learn about what's important to you. Now, this is a study that went back and looked at a population of patients to see whether or not interruptions in their treatment caused them to do worse. And the short answer is no. But these patients had modest interruptions of like 4 or 5 days during their course of radiation. So here are my conclusions about delays. Low-risk patients, people with low-risk disease, this is why active surveillance is such a great thing, because there's no good evidence that you can wait years in people with with low-risk disease, and you still can't tell a difference between those people that got treated initially and those people that waited. For intermediate risk, easy 6 to 9 months, and if you add hormone therapy, probably longer than that. Same thing about high-risk disease, but you do need to give local therapy to those people with intermediate and high-risk disease if their life expectancy is long. And minor interruptions in the course of treatment do not appear to be a big deal. So now I'm going to shift to some biomarker stuff. I skate to where the puck is going to be, not where it's been. So there's a whole body of literature, and time won't permit me to go over this. I think, didn't you have Dan Spratt here one year or something? No? You did? Anyway, he talks a lot about these. This is one of his slides. This is looking at the so-called Decipher, what these bar graphs tell you is that incorporating that information gave you a better opportunity to predict who was going to get metastatic disease. And then this is using that same kind of technology to tell you who needs high-dose radiation. So this is now published data. So not everybody benefits. If they have a low Decipher score, they don't need dose-escalated radiation. They could go with lower dose radiation, and the patients with higher risk disease appear to benefit most from high-dose radiation. This is the newer stuff. This is artificial intelligence data. This is from a company called Artera, which I have no stock and no conflicts. But the tissue bank is at UCSF where I work. And what they did is they accessed more than 5,000 patients from these studies that we were involved in doing. And basically what they do is they take the slide and they're able to image the slide And using this deep learning algorithm, the computer recognizes things that the pathologist didn't recognize. And the beauty is they don't use up the tissue like you do with some of the biomarker stuff. And these are just the studies, and again, the ability to improve on what's been done before with predicting outcome. And it turned out that you could tell that, and this is now FDA approved and available in most states in the United States, but not California and not New York. So in theory, so this is a study that was published last year. If you have a low risk Artera score, you don't benefit from hormone therapy. So if you're going to be treated for prostate cancer, you can actually, I got an email today from a patient that I never met in person. He's the colleague of a friend, a medical doctor, who contacted me and wanted some advice. And I said, well, you know, if you're thinking about doing hormones and radiation, you should, you know, you live in a different state, you should get this test. And he did the test, and it said that he's got a low risk Artera, and so he's not going to take hormone therapy. The people that have the high risk, they were the ones that benefited, and if you look at the data, it looks like that 2/3 of the people didn't benefit. So most people won't necessarily have that signature that suggests that they do need it. And when we do a large study with 2,000 patients and it shows that there's an advantage to using the hormone therapy, that advantage is being driven by that small population of patients that have it. And so with these genomic biomarkers, most of them are prognostic, meaning that if you have that, it tells you got bad disease. It doesn't necessarily tell you what to do about it. But this AI model not only tells you got bad disease, it can tell you whether you need to use hormone therapy. It's cheap because it's computer interpreting. It's fast and will be globally available and so forth. So I predict this is going to be a big driver in how patients are managed going forward. Now, I'm going to, in the interest of, how are we doing on time? Because this race thing is kind of complicated. I can skip through it if, you know, so I'll go through it quickly. So 30 years ago, everybody was saying prostate cancer is inherently more aggressive in African American men. And I was like, no, it's not. They said, yes, it is. I said, no, it's not. And to make a long story short, people believe that because it's more common in African American men for sure, but the mortality rate was higher. And people were proposing that there were these genes, it was a genetic thing, and I won't dwell on, you know, whatever race is. The anthropologists say there's only one race, the human race anyway. But there were papers like this published at Kaiser. Prostate cancer race survival from an HMO, and the bottom line that they concluded was that these findings are most consistent with the hypothesis of increased tumor virulence in blacks. This is what they published, and I wrote a scathing letter to the Journal of the National Cancer Institute. We're talking about more than 20 years ago. So this was dogma in those days. And I said, you know, I won't even go into what I said, but this pattern was persistent in SEER data, surveillance epidemia. This is national data showing lower survival rates from prostate cancer in African American men. And part of the problem was, this is an example. If you take the year 1988, over 50% of black men didn't even get treated. And, you know, there were different statistics. And so these sort of survival data don't take into account quality of care and that sort of thing. And then in terms of the incidence, this is an old study in the pre-PSA era that shows, this is the prostate cancer in whites. This is prostate cancer in Chinese men born in China, living in China, born in China, moved to the US, and born in the US and living in the US. Now, some people interpreted this study to show, aha, you know, it's a genetic thing. I'm saying, well, I tell you, when I want to pick a good Chinese restaurant, I look in the window, and if I see a lot of Chinese people in there eating, then that's where I'm going to go pick my Chinese food from, okay? My wife is Chinese, and she kind of explained that to me. So I know how to get some Chinese food. So the dietary habits have something to do, lifestyle have something to do with this trend toward the Western lifestyle and the Western race. Albert Einstein was once asked, if you had 1 hour to save the world, how would you spend that hour? And he said he would spend 55 minutes defining the problem and 5 minutes solving the problem. So you got to do some research, some due diligence. And this slide right here summarizes 12 randomized trials. So what these randomized trials do is they took in patients, they signed a consent, they had to have the same amount of disease, the treatment was controlled. And then, and these are reports where they went back and looked at how important was race. So of the randomized trials, only one of them suggested that prostate cancer was more aggressive in black men. 8 of them said race was not important at all, and 3 of them said African-American men actually did better. The ones where African-American men did better are more recent and larger studies. I don't think race is important in terms of prostate cancer prognosis. And this is data that we have under review using artificial intelligence and divided by race. It really doesn't matter. People should get good treatment, and that's the bottom line. So it's tough to make predictions, especially about the future. So my bottom line is that cancer research is dominated by drugs. There's a whole lot of exciting research being done in radiation, which I didn't get a chance to talk about. Radiation is extremely cost-effective and effective, and there's tremendous potential for it to get even better. And this is my last slide. Einstein said, not everything that counts can be counted. And not everything that can be counted counts. And I say, count what you can count and hope it counts.
That was fabulous, as always. And I don't think you have much of an opinion when you give your talk. That's sarcasm. All right. I thought, what can we cover first? Let's go with my first slide. Okay. Here's what I'm thinking, because we're way out of time. That's so weird. You took more time than you usually take. Look at this one. All right. You got to know, I've known this guy for 30-some years. I mean, he looks great. He's 94 years old and takes great care of himself. But he was all into brachytherapy, conventional radiation, and now all he talks about is SBRT. Okay, so all you people are selling SBRT. So first, explain what SBRT is and why is it taking over everywhere in prostate cancer? Is it because you make a lot more money from SBRT?
So let me rule that last one out first. I am an employee of the state of California. I'm a salaried employee. I don't make more money, so I'm not here trying to recruit more patients. Let's be clear. I'm an old man. I'm thinking about retiring one day. But anyway, and you have to understand that it's a bit of semantics. So the only difference between intensity modulated radiation and stereotactic body radiotherapy is that we use larger size fractions. So with intensity modulated radiation, if you're radiating the prostate, you can give a little bit of radiation every day and you can use image guidance. And so you can give 200 a day to, say, 8,000, or you can do 1,000 a day and finish it up in 4 days. The logistical issue has to deal with the reimbursement. So what happens is that doctors will negotiate with some of the funding agencies, and they say, well, if you're going to do that one, the SBRT, you can only do 5. Now, I usually use 4, but most people do 5. And you got to understand, radiation oncologists are paid by a weekly management fee. So every week that you see the patient, you get paid. So if you drag the radiation out longer, you get paid more money. But if you don't care about that, then you're more interested in figuring out, well, Mr. Jones, I'm gonna hurry up and get you done right here. I can go home, you know. Then you have a shorter course of treatment. So SBRT is when you give more dose in a shorter period of time, you have to be very precise in terms of how you design the anatomy. Again, there's a thin line between love and hate. You have to worry more about the bladder and neck. You have to worry more about image guidance. So you do need to be a little bit more precise, but that's basically, it's x-rays, but you can also do stereotactic body radiotherapy with protons. You can do it with carbon, which are other types of radiation, but not in this country.
So who's a really, really good candidate for your treatment?
Favorable intermediate risk.
Favorable intermediate risk.
Favorable intermediate
Thank you.
risk means your Gleason score is 7, like 3 plus 4 is 7, and most of your biopsies don't show cancer. You might have 12 biopsies, maybe 4 of them or 5 of them show cancer. Your PSA is below 10, but you have a Gleason 7. That's a typical, if your prostate's not huge and you don't have a lot of baseline urinary symptoms, that's 4 radiation sessions. That's Monday, Tuesday, Thursday, Friday, done. Okay? If you become unfavorable intermediate risk, meaning instead of 3 plus 4, it's a 4 plus 3, or more than 50% of your core is positive, or your PSA is higher, then I start thinking about, well, do I want to add hormone therapy to the mix? And I start thinking about, do I want to worry about the lymphatics? So for those patients, I would then order a PSMA PET. As soon as they get unfavorable intermediate risk, if they have a high decipher, if there's other things that make me worried about their disease, then I want to do a PSMA PET to make sure that they don't have any evidence of lymph node involvement. But I'm thinking about doing more if it's unfavorable intermediate risk, and certainly if they have high-risk disease, then hormone therapy is indicated, either short-term or long-term, depends on the circumstance.
Who's a really bad candidate for SBRT, the treatment you give? Like you just don't even exercise the option.
A patient with bad baseline symptoms, people that are already on Flomax or tamsulosin, like 2 pills at night to pee, and they're still getting up 3 or 4 times at night, and they have trouble emptying their bladder. Because see, I published a series in which we had a few patients, I think it was 4 patients, that came in the door completely obstructed. They couldn't pee, but it was due to cancer. They do great with SBRT. I was able to get them catheter-free in a relatively short period of time. That's because their obstructive symptoms are due to cancer. But if they have obstructive symptoms due to benign prostatic hypertrophy, or some type of dysfunction in their urinary tract where their bladder just doesn't empty completely, they're not a good candidate for SBRT. They tend to become obstructed and miserable. I have one guy who's pretty miserable right now, and that's the first time I've ever had this. It's been years and years and years. And you know, he's doing self-catheterization. I mean, he didn't have a lot of good options, but the bottom line is this does happen, and those are not the ideal patients. In fact, sometimes people ask me, under what circumstances do you recommend anybody have a radical prostatectomy? That's a pretty rare event. But one of the circumstances in which I recommend somebody has a radical prostatectomy, if their baseline urinary symptoms are serious enough that they're going to have trouble emptying their bladder, and they have ED already. If you already, if you're not sexually active and that's not an issue for you, but you have trouble emptying your bladder, maybe have your prostate removed, you'll pee bladder, and you'll be happy.
So that bad candidate that you said is not good for your treatment, you send them to surgery, or do you send them to another different type of radiation?
I prefer to send them to surgery. One of the reasons I prefer to send them to surgery is that the surgeons always say I never send them patients. So take this one right here. This got somebody just for you,
Gee, thanks.
Yeah.
Okay, so that's who, okay. Will you tell people, I don't think a lot of people understand that there's no better word than if you hit the prostate with all that radiation, even short term, what actually happens to the prostate? It shrinks. I mean, what happens anatomically? And so are you also, is part of the reason that you get the PSA drop and the shrinkage of the prostate when you hit it with radiation Is that because you're killing tumor and BPH, or how does that work?
Well, you kill more tumor than you do BPH.
Okay.
But if you're given hormone therapy with radiation, the hormone therapy is going to shrink the prostate more than the radiation does. So most of the shrinkage occurs the first month, the next most in the second month, and the next most in the third month. Radiation will shrink the prostate. It depends on the dose of radiation. So if you look at patients that have brachytherapy, old-fashioned LDR, where I used to put a lot of little seeds in there, those prostates would really shrivel up and be destroyed in the glands. So that kills cancer, and there are some benign cells that will die as well. One of the things that, actually, it was a patient's wife who first called me up and said, Dr. Roach, you told me if I noticed something, to let you know. I was like, okay. And she said, he doesn't make as much as he used to. The volume of his ejaculate went down. And I was thinking, gee, what an observant wife.
I thought you were talking about money. I didn't know you were talking about.
No, I'm like.
I was like, well, no one makes as much as they used to.
I was like, oh, I said, that's normal. There was nothing in the literature at the time. This is like 30 years ago, right? I put it in my next book chapter as a side effect of radiation. Because when you radiate the prostate, it gets smaller, and if you go back and biopsy, it's fibrotic, but it's not a form of birth control because the sperm cells are still made in the testicles. It's just the volume of the ejaculate goes down.
Okay. Can you tell the audience about these markers that you put in? They're called fiducial markers. And I know the radiation oncologists, to me, love to run around and go, we just put a couple of these markers in, they're no big deal. And then people will call me and go, oh, these markers, they put in these seeds, sometimes they hurt. So tell us why you need them and how many do they need, and are they really made out of gold so you could reuse them?
Well, we use 24 karat gold. But I think that reduces the infection rate. But I don't put them in. I have my urologist put them in. And I have my urologist put them in because when you radiate patients, you need to give the urologist something to do too, right? You let them put the gold seeds in. And also, they're better. They use the ultrasound all the time. So I never thought I needed to master ultrasound. They got people, this is what they do. They do the biopsies. Look, put the gold seeds in. They got good reimbursement for it.
How many do they put in?
They usually put in 3.
How long does it take?
Probably about 15 minutes or so. But one problem is that occasionally they don't put them in the right place. So some urologists are masters at it. I have one guy that my physicist was giving a lecture at a physics meeting talking about the need for image-guided radiation. And he was showing them the slides. And somebody said, excuse me, can you show me a different patient? You keep showing the same patient over and over again. And they were all different patients. He was so systematic about how he put them in there that they looked like it was the same patient. And I just had a patient last week that we were doing his planning for SBRT, and it turned out one of the seeds was put in the external sphincter, and one of the seeds was put in the rectal wall, and I had to send him back and say, listen, can you put 2 more seeds in the prostate this time? Because I kind of, because what happens is the prostate position is variable, depending upon the filling of the bladder, the filling of the rectum. And so every day before each treatment, we reposition the beam based on where the prostate is, and you can treat patients within a couple of millimeters in terms of accuracy. But if you have a seed that's in the rectal wall and a seed that's in a muscle that's not moving, then you can have a problem in terms of being able to line things up and do accurate treatment.
So they stay with you forever?
Yes. I tell patients, tell your wife you're worth a lot more now than you used to be. It's about 2 cents worth of gold.
Yeah, you have less volume, but now you've got gold.
Yeah.
Okay. There's a name you've used that I've never seen talked about much at these meetings because it's probably so new, and that goes to the second question that people ask a lot. You answered the question of how do I know if I need hormone therapy, and you brought up a company called Artera. Uh-huh. Tell me how that works. How do I get that or another test if I'm looking to get that answer? Because you said it's available in some states.
It's not available in California.
So what?
And it's not available in New York. So it has to deal with, I don't quite understand the rules, but it has something to do with AI. So it's FDA approved. So I have had some patients that lived in other states, and they called me up and I said, oh, you can get it. And they've gotten it. And then I had a couple of patients of mine that I saw, and I said, do you know anybody in Nevada, or, you can go just drive. And one guy went there, and he tried to get them to order the test, but because his specimen was in California, there was a problem with it. So I'm not quite sure. I know you can get the test in other states. You can get it in Washington, D.C., for example. I have a colleague, a classmate of mine, who got a test in Washington, D.C., and it suggested he didn't need hormone therapy. He was very happy.
And you feel confident in that data that they get this test?
Okay, so
or is this
the tissue bank at UCSF is partly at UCSF because I helped bring it there. And we have, the analysis is based on over 5,000 patients that were treated on randomized trials that I participated in. And I know the people that put the company together, and I don't have any reason to doubt it.
okay?
So
Check the website, basically. I mean, I looked at the website. It's impressive, but what do I know? I mean, but it's a good option because really there hasn't been much direction, so that's a good place to go, right? So they need to ask about it.
Well, the other thing is that in the near future, I think we're going to have, for example, I have a study that I just completed that I'm in the process of analyzing. 2,592 men were randomized to only have radiation to their prostate or radiation to the prostate plus the lymph nodes. We will be analyzing the tissue. I predict that one day we'll be able to say, okay, you need short-term hormone therapy, you need long-term hormone therapy, you need a higher dose of radiation, you need to have your lymph nodes radiated, but you don't need hormone therapy, and you don't need to have your lymph nodes radiated.
The radiation oncologists they don't answer this question, so can you represent this? Okay, you get treated with radiation. Is a real fast drop in your PSA a good thing, or because you deal with these stubborn PSAs, they take a while, they're recalcitrant, and then they finally drop. I would think that if you're being radiated with or without hormones, if you get a fast drop in PSA, that's a good prognostic indicator. Is that wrong?
Well, it depends on how far it drops. So there are some studies that suggested that people that have fast drops did worse because they didn't go down very far. They went down, but they didn't go down far. There are studies, so it really depends on how you analyze the data. I have a paper that I wrote years ago with one of my residents. There were some people whose PSAs were still going down at 3 and 4 and 5 years after they were radiated. So would you call that a fast drop? No, but it was a low drop. The PSA was still going down and down for years. So it's a complicated thing. And of course, if they're a high-risk patient or an unfavorable intermediate-risk patient, the rate at which the PSA drops is going to be driven by the hormone therapy, not the radiation. Because the typical pattern of response to external beam radiation is that the half-life of PSA in the serum is about 3 days. So if you take a man's prostate out and their PSA was 20, 3 days later on average it's about 10. And 3 days later on average it's about 5, and so forth. But when you radiate people, the half-life of PSA is about 3 months. So if they have a PSA of 20 and you radiate them and you check their PSA 3 months later, it's 10. And then 3 months later, it's 5. So if you're combining hormone therapy with radiation, it's really the hormone therapy that's driving the PSA decline. But the nadir, the NADIR, which is the lowest level you get, it does give you some information. Mostly if your PSA, so we did a study with 1,200 patients, and the study was designed to define a complete response in terms of hormones and radiation if your PSA went less than 0.3. The median decline was 0.2. So if 6 months after you've been treated with hormones and radiation, your PSA is 0.7 or 1, that's not good. Now, it doesn't happen to a lot of people, but it does happen to some people. So the bottom line is that It's not a rapid, it depends, so it depends how far it drops. It depends on whether it's still going down. It depends on whether they get hormones. I mean, it's a complex question.
Okay, what about the other way, the recurrence? Can you tell the audience what, you all got relied on this thing called the Phoenix definition. You remember this Phoenix definition that's still in the literature? Will you tell the audience what the Phoenix definition is? And is that just blown apart now because of all the great imaging going on? So can you just walk people through that?
No, so in radiation oncology, we used to have something called the astro definition, when we radiated people to say, okay, this is what a recurrence looks like. Well, it turns out there were a bunch of problems with the astro definition. So in 2006 or 2007, we published a paper called the Phoenix definition. And the reason it was called the Phoenix definition is two. One is the meeting was held in Phoenix, Arizona. And the other one is that there's this methodological phoenix that arises from the ashes. So we said, oh yeah, we'll call it the Phoenix definition. So the Phoenix definition is you give a patient radiation, and if the PSA goes up by more than 2.0, that's considered to be a biochemical recurrence. Now, that's the definition that's still used today. Now, I don't really like the Phoenix definition. It was negotiated, sort of like, healthcare or something. We negotiated. I wanted to have two definitions: biochemical failure, which meant your PSA was going up, and bioclinical failure, which means you could see something that was meaningful. But I lost, and we came up with the Nader +2 definition. So that's the standard definition. Now what's happened is a lot of urologists will try to take that same definition and use it for people that get cryosurgery. They like to use it in people that get HIFU. It wasn't created for that. It should not be used for any of those things, but it's a reasonable endpoint for patients that have had radiation.
These are quick answers. If someone gets radiated, prostate or not, you can answer it any way you want, and then they get recurrence, it comes back, generally speaking, in your research, where does the disease come back? Does it come back in the anastomosis? In other words, explain where...
Is it in a post-op or a patient definitive?
Both. I wanted to know a couple scenarios.
Okay, in patients who have radiation, the most common place for people to recur, now if they're not extremely high risk, is the same spot where most of their disease was in the first place. So if you have a patient that has, 5 positive biopsies in their right lobe, you give them radiation, and their PSA starts to go up, the most likely place for them to recur is in the right lobe. And that's why when we institute what we call salvage radiation, I just radiate the right lobe because the left lobe was already radiated and it didn't have much disease there, and they're not likely to have a recurrence there.
So you do radiation after radiation?
Or you could do cryo, you can do prostatectomy, yes.
HIFU.
But I think the morbidity is less with radiation.
Okay, so that's interesting. It comes back in the same area. Now give me the other one you were thinking about in a different scenario.
In the post-op setting, depending upon the pathologic stage, the most common place might be in the pelvic lymph nodes. So you do a PSMA PET, and you see some lymph nodes light up. Now, there was a patient who came up to me earlier, a Kaiser patient who came up to me earlier and said, I had a radical, I had a recurrence, they did a PET, and the PET didn't show anything, and but there's a nodule in my bladder neck. And I'm like, well, you need to get the nodule in your bladder neck biopsy, because what happens is when you do a PSMA PET scan, the PET agent fills up the bladder and washes out the whole bladder with a bright spot. And if you have a nodule right at the bladder neck, you won't necessarily see it because of the shadows from the PET agent. But if they can see the nodule on ultrasound, they should stick a needle in it. And then if it's positive, you can put some gold marker seeds around that. And I've done that and seen that. And you can treat that area. And it's much easier to treat, but you need to add fiducials, and it needs to be given a high dose of radiation.
All right, do you think you can answer this next question in 30 seconds?
Yeah, obviously.
Well, you're kind of a bummer right now. I mean, can we go to slide 4? whenever I want to just see how you're doing, you just start talking about the future and this thing called carbon ion radiotherapy. Can you tell people, this thing is very interesting, tell people why we need to be looking out for this next wave of radiation therapy? Because it's being delivered around the world.
Well, so in radiotherapy, we talk about something called an RBE, radiobiological effectiveness. And in animal models and stuff, carbon has an RBE of like 3 compared to X-rays and protons. So in theory, we should be able to kill more cancer. And it has a narrower, what we call penumbra. That is, the beam is less fuzzy on the edges. But I don't think this is really what we're talking about. We don't have this in the US. You know, we do studies on it.
It's being done in Japan, though. I mean,
they have 6 centers in Japan, or 6 or 7 centers in Japan.
So you don't see it coming here anytime soon?
Not in the near future.
Okay.
What's more exciting is flash radiation. So it turns out that when you radiate somebody, if you can give the radiation fast enough, the biochemical mechanisms and pathways that are involved in toxicity can be avoided. So they have animal models where they show you radiate the brain at one dose rate compared to another dose rate, and you can avoid damage to nerves and vessels. Same dose of radiation, because the biochemical pathway. So I think, and the other advantage of flash is that because the radiation is delivered so quickly, you don't have to worry about motion. So it's sort of like if you're a photographer and you're taking a picture of a race car, and the race car that your film is so fast, the race car is frozen in space. So if you can treat like a lung cancer, the person's breathing, but you can deliver the radiation so fast, you can treat the lung, you can treat the tumor that reduces the dose to other tissues. And if the flash really works.
So are we going to see that soon?
Not real soon. I think it'd be like 10 years, and I don't, you know, we're still working out some of the details, but I think it's got the most potential of any of the forms of radiation, I think.
So we're about to finish and give you a round of applause because you always do such a good job, but you can't. But don't give him a round of applause yet. He has yet to leave the very end of this, and the very end of this looks something like this. I thought I would send you a surprise this year, and can you bring up the next photo? Can you tell me what this is? My next slide.
There you go. So this, my daughter.
He didn't know I had this.
That's true. My daughter Sarah is in the middle with her new husband. She just got married July outside of Bath, England. She married a British guy. There's my wife on the far end, and then Tom's parents on the other side. A very special moment.
That's sweet. So around his daughter just got married. I was. When I looked at the photo initially, first I thought a few things. First of all, the guy's a lot taller. I would be intimidated. I mean, he's the son-in-law, you know, so now that's a problem. Then I thought, that looks like an expensive wedding that only a radiation oncologist could pay for. And then the other thing I thought was the beautiful woman essentially on your right and the far left, I thought that was your other daughter. But that's your wife, Debbie, who's just been absolutely amazing. And Sarah, we've known them most of our lives. They're just a fantastic family.
Sarah was there. Sarah's a witness. I took him out in the backyard and schooled him in basketball. Okay.
So Sarah and his wife are huge Michigan fans, but he won't let him celebrate the fact they're Michigan fans because he's a big fan of the San Francisco sports and blah blah blah. And so he keeps denying that his wife and his daughter are big Michigan fans. He's like, no, they don't care about Michigan. Can you show him the next slide? If they don't care about Michigan, what happened here exactly? I don't. And can you show the next slide again? What happened? What is that? So I guess they're not Michigan fans? They sent me that. That's kind of awkward. The next slide I want to quickly run through before we call it quits. Oh yeah, what's that wine you have in your hand? That's Charles Woodson wine. That's a University of Michigan wine player, right? So you're doing well on the fact that you don't like Michigan. All right, so let's go to the next slide. So I thought of you when this happened. So I went to my local post office, and they now have a Hank Aaron postage stamp, which is long overdue. This is great, right? And I hate to throw this in every year, but it is kind of awesome. Why would you be proud of that from a personal level?
Well, he's my uncle. And I was in the family box when he hit 7:15. I was sitting there going, oh, man. I was young then. I know,
but you were in the box when
I had hair. I was young. I was skinny.
You are skinny still.
Yeah, I know.
You're the second most handsome person on the stage.
Yeah.
So the other thing is, but that's a historic moment, and you were close with him. You know, like I always say, I've known him most of my adult life, and he was very close with Mr. Aaron. And it's sort of perplexing, though, because, you know, he's such an incredible athlete. And I'm just thinking, where did your athletic skills go exactly? But I want to explain what I mean by that. I want to explain what I mean by that in a second. But the reason why I put this here actually is to send you a compliment. And that's why I'm so glad all of you stayed. Because Hank Aaron was Hank Aaron in baseball. And as much as we go back and forth, this is how our conversations are on the phone. They get nowhere. We just completely razz each other. You sort of hit a status with me on another level, which makes me a little bit verklempt. Can you go to my last slide? In the next month or so, the highest award honor given to a radiation oncologist globally this year will be given to Mack Roach. So you became the Hank Aaron of radiation oncology, right? Even though you're not athletic at all. So it's called the Gold Award. So you're going to accept it, I think, end of this month?
Gold medal.
Gold medal. So I thought I would get you a gold medal. Right? All right. And then when I played basketball at his house 15 years ago, he still lies to his patients. He didn't score 1 basket out of 10. So in my world, you get a silver medal, too. But to leave you with the fact that, you know, I love you. And I thought this year, you know, everything that you've done for us, this is the year we give you the Oscar for Best Radiation Oncologist, Mack Roach. I love it, man.
Thank you.
All right? Thank you.